Okay, Saad, I think we've covered some of the questions that were listed there. I think it's time to take a look at all of these exciting new immune therapies and how do we handle relapse in the first instance, and then how do we integrate into that some of the therapies that we've used for relapse versus these new exciting cellular and antibody therapies. So please welcome Dr. Saad Usmani, who is now the chief, I was going to say the head, but no, you're the chief of the myeloma service at Memorial Sloan Kettering in New York, having moved from Charlotte, from the Levine Cancer Center there. So welcome.
Thank you so much, Brian, and it's a pleasure to be on this panel with you and with Rafat. It's and I look forward to meeting in person. Probably next month, for the summit. So I'm going to try to cover the relapsed myeloma landscape and try to build on what both of you have talked about, and then we would love to have a question and answer session, and address other questions and concerns that patients may have. These are my disclosures, and I'll try to start off by sharing that journey to that first relapse. I think for the most part, regardless of whether patients are, transplant eligible or ineligible, if we look at the landscape of myeloma treatment internationally, patients are receiving more 3-drug and 4-drug combinations today based on all the data that has been shared, and very rarely now do we use 2-drug combinations. But I wanted to share the data there just to give an idea of all the different treatments that patients receive, and then as patients get into maintenance, typically it's with 1 or 2 drugs at the moment, as a standard of care. So the expected median PFS, or progression-free survival, the period in which the patients remain in a good response after initial treatment until the myeloma starts acting up, those average months of median PFS that I've shared on the slide reflect the disease biology, whether patients have high risk or standard risk disease. So as you can see, we have patients who have different treatments and different disease biologies, and when they're relapsing, there are many different considerations that we have for them in deciding treatment. And the way that we think about this is, there are patient-specific factors, which include their age, other comorbidities, performance status. Then we also pay attention to how the disease is relapsing. Are there any high-risk features to the disease? Is the disease now, are there myeloma cells circulating in the bloodstream, which is a little atypical and perhaps, tells us about the myeloma getting aggressive, or is the myeloma now spreading to lymph nodes or soft tissue or other organs outside of the bone marrow? That's called extramedullary disease. And then we also pay attention to what were the previous treatments received, what kind of side effects patients had, and I think one of the patients in the question mentioned the risk of second primary malignancy, which happens in a very small proportion of patients, but it's something that we do pay attention to as we're thinking about the next treatments in myeloma patients. So all of these things are taken into consideration. The good news is that for our early relapse patients, we have many options. We have many 3-drug and 2-drug options with lenalidomide based combinations, carfilzomib based combinations, pomalidomide based combinations, and then there are other treatments like selinexor being approved with one of the proteasome inhibitors, bortezomib dexamethasone. And then for translocation 11-14 patients, there's a drug venetoclax that is quite active, and for certain patients we can actually get it approved through their insurances and use it to good effect. So, I wanted to mention all of these options to give an idea of measured hope to our patients, that we have so many options. I still remember a time, and I'm sure, Dr. Dury has actually been such an integral part of, this therapeutic landscape journey, that we did not have many options. We only talked about one or two drugs even when I was in my training trying to become a myeloma physician and researcher. So we have come a long way, and there are so many other options that we have for our patients. As we think about all of those factors, when patients are relapsing for the first time, we want to see if they have been on lenalidomide and are progressing on it, because the treatment options for those patients are going to be different than patients who are not refractory to lenalidomide. And then, for patients who relapse after that second line of treatment, we try to use options that have been not used before, or try patients on clinical trials. And then autologous stem cell transplant for young patients who either did not receive a transplant as part of their initial therapy, or they actually had a very good response to that initial transplant. That's something that we do consider for patients. But what about later? And this is where there is so much excitement about the promise of T cell redirection. So what does T cell redirection mean? T cells are a very important part of our immune system. There is a strategy called CAR T cell therapy, where we can take a patient's T cell, teach that T cell through introducing an engineered protein moiety to help recognize the cancer cells. And in this case, there is a protein called BCMA on the surface of myeloma cells that these T cells are taught to recognize, and then they're grown ex vivo or outside the patient after the collection. And then once they've expanded, when we have enough quantity, we give patients a lymphodepleting chemotherapy and then infuse those T cells, and these T cells then go identify myeloma cells and take them out, and they also expand. So that's one way of using patients' T cells, and we now have two CAR T cell therapies that are actually approved for advanced myeloma patients. Then the other technology is what we call bispecific antibodies or bispecific T cell engager, and the difference between those two is the peptide structure essentially, but they're doing the same thing. One part of that structure can recognize the surface protein, a specific surface protein on the myeloma cell, and the other part recognizes CD3 on T cells. So, so it brings patients' T cells to the cancer cell and helps kill the cancer cell. And if we look at the CAR T cells, and I promise I'm not going to be taking a quiz from you guys on this. You don't have to remember all this data, but the only part I've highlighted is how impressive the responses we've seen with CAR T cell therapies. If we look at the previous drug approvals we've had in myeloma, with pomalidomide, daratumumab, carfilzomib, all those drugs, the overall response rate was between 25, 30% of overall response rate. And here, for well advanced patients who've seen 5 or 6 or more prior lines of treatment, we are seeing responses well over 65, 70%. And in case of cilta-cel, which is an FDA-approved BCMA CAR T cell therapy, in that single arm trial, the overall response rate was 98%. Almost every patient responded. So very remarkable results with CAR T cell therapies, have been seen, and we have two approved, products that we utilize for our patients, and we are starting to now move those treatments into earlier lines. So here is an example of ide-cel, which is a BCMA-directed CAR T cell therapy. In fact, it was the first one that was approved by the FDA. So this is data that was presented at ASH, where we looked at patients who have early relapse after autologous stem cell transplant and what happens to these patients if we give them treatment. So this was a group of patients, who did not have a good response to their initial treatment. In fact, only 24% of these patients had a complete response. And when they got this CAR T cell therapy, the overall response rate is 84%, but look at that complete response rate, 46%. Even better than the first line treatment, is what they got. So, similar kind of results have been seen with the cilta-cel as well. But, the bottom line is, for our difficult to treat functional high risk patients who are relapsing early, these CAR T cell therapies are showing very good promise. So, we're looking forward to having, these therapies available for our patients in the future in earlier lines of treatment. And it's not that BCMA is the only target. We have another new target called GPRC5D. Again, my previous, colleague Eric Smith, who is now in Boston, he actually, as a fellow, identified GPRC5D as a target in myeloma and started to develop a homegrown CAR T cell therapy. And that GPRC5D directed CAR T was then licensed to BMS for further development. And this is the data, early data that was shared at ASH with some of that experience. So, heavily pretreated patients with high proportion of patients with high-risk cytogenetics as well as extramedullary disease. And then 40% of these patients actually had a prior BCMA-directed CAR T cell therapy, and additional 15% had BCMA-directed other treatments. So with this patient population, you can see that very high response rates were seen with this particular CAR T cell therapy. If patients did not receive a BCMA directed treatment, 100% response rate, and even in those who had prior BCMA, 78% response rates were seen, and very high rates of complete responses. And even though the numbers are small, this is a very important slide demonstrating to you the wonders that these immunotherapies can do for our patients. So we're really looking forward to further developing this specific GPRC directed CAR T cell therapy for our patients. If we look at the safety profile, so it's not just important to take a note of the activity, but we also want to see if we can manage the side effects of these therapies. And so what was important to see that unlike some of the CAR T cell therapies that our lymphoma colleagues use, the neurologic side effects appear to be lower than that patient population for our myeloma CAR Ts, whether it's BCMA directed treatments or GPRC5D directed treatments. I think one thing that we all are concerned about and have to keep an eye on is the infection risk for patients as these therapies are utilized more in clinical trials. So the other important group that I talked about is bispecific antibodies, and this slide actually shows you the why there are so many different ones. So depending on the structure, these are bispecific antibodies or T cell engagers can take different parts of the immunoglobulin structure, put them together, and that creates different kind of half-lives for these antibodies, and different kind of targets that they can bind to. They can bind to the same target but different parts of that same target. So that's why you're going to see a lot of these different bispecific antibodies. They're going to vary in the kind of characteristics they have. And teclistamab, I appreciate Dr. Dury actually giving me a shout out for, helping with this, first FDA approval A lot of hard work and contributions from our patients, caregivers, as well as the study team. But there are many other bispecific antibodies that are coming down the pike. So teclistamab was our first one, first BCMA-directed bispecific, but we also have elranatamab, which is knocking at the door for an FDA approval. We have the the AbbVie-383, which used to be called the Teneobio 383B. We have elnuctamab. We have the Regeneron, a bispecific, which is now called linvoseltamab. So, we are going to have many different bispecifics. The good news is each of them are very active, but they're probably going to have different, schedules because of half-lives. And, we'll have to figure out, how best to use them in the clinic, and then for academic centers, the use may be a little different because we have access to, a more dedicated inpatient service that can care for these patients. Whereas for our community colleagues, the challenges might be a little different. So we have a lot of work to do on working out the logistics. So elranatamab, very similar to teclistamab, the overall response rate for, a relapsed refractory myeloma patient population, patients who've seen 5 different lines of treatment. Again, response rates very impressive at 61%, very similar to what we saw with teclistamab at 63%. And, the good news about, if you look at this progression-free survival curve, there are patients who have stability of response. So there is durability of response with these bispecific antibodies. However, the important, risk that we need to, consider is the infection risk. And that's what you see in this right table here. The way that the original bispecifics were have been studied in clinical trials is to continue giving them on a weekly or every other week basis, depending on their structure and their PKP, pharmacokinetics and pharmacodynamics, their half-lives. But we are now learning that we can give it less frequently to patients or give it for fixed duration of treatment. So that infection piece, is something that we as researchers are looking at right now to help make it a better option for our patients long term. And all of us have those anecdotal patients who've been on these therapies now for many years on clinical trials. Elnuctamab is another bispecific antibody. It's showing again, very similar kind of response rates, and the same, signal that we see, with infections is being seen with this particular antibody as well. And I think it has to do with the BCMA bispecific, portion of it. And again, overall response rate very similar, in the 60s percent. So overall response rate of 65% being seen with this particular bispecific antibody as well. And instead of just going on and on about the BCMA ones, I wanted to talk about telquitamab. And I'm sorry, my slide, because of the, I guess, MacBook versus other, the formatting changed a little bit. So telquitamab isn't showing up the way it should. But the development of this particular bispecific was led by my colleague Dr. Ajay Chari, who's actually moving to the West Coast, Dr. Dury, to be
That's
closer
right,
to you in
San Francisco.
Yes. But this bispecific showed very high response rate in this in the 70% range, and 2 different doses were studied. The 0.4 milligram per kilogram being given weekly, and the 0.8 milligram per kilogram being given every other week. And it looks like the durability of response may be better for the Q2 week dosing. So the data looks promising. I think this is going to be this is being examined by the FDA right now. So we'll get a better idea of the approval timelines, I guess, later in the summer. And even in patients who have had prior CAR Ts or prior bispecific therapy, we're seeing response rates of 62.7%. So it's important to see that if this is an important question that I think many doctors and researchers are asking, how best to pick one treatment versus the other. Can we sequence treatment? And what we're finding with these different treatments is that patients do respond to other therapies, in terms of sequencing. The response may not be as robust or good, but but patients do respond to treatment. So I think that's another message, that you can go from one treatment to the other, either immunotherapy treatment. And then with GPRC5D, we just learned about this new bispecific called forimtamig. So forimtamig actually has two different epitopes or parts of the GPRC5D structure that it binds to. And initially it was looked at as an IV formulation, and now there's a subcutaneous formulation. And the interesting thing about this one is the dosing is every 3 weeks, so it's not on a weekly basis like telcitamab. You can give it less frequently. So the data were early, but response rates, again, in a very similar kind of range. You can take one structure and show the same kind of responses in highly relapsed refractory myeloma patients. And the safety profile, any cytokine release syndrome kind of side effect that patients get, it's, quite manageable. Grade 1 or 2 for the most part. Very few patients get, high grade symptoms. And just to give you an idea, when we I think we had Anne wonderfully talk about what cytokine release syndrome is, but grade 1 cytokine release syndrome is just having a fever and taking Tylenol. So I think understanding these grading is important for patients as well. But it's very, very manageable. And then how do we, there are also efforts to improve cytokine release syndrome. So, there is a medicine called tocilizumab that we typically give to patients when cytokine release syndrome happens. But in this study, Dr. Trudell, from a wonderful colleague from Princess Margaret Hospital in Canada, in Toronto, Canada, she did a study where she compared giving cevostamab, which is a bispecific that targets a different surface protein called FcRH5. They did a study where a group of patients did not get any preemptive tocilizumab. Another group got tocilizumab to prevent CRS, and they saw quite a bit of reduction in the overall percentage of CRS between one arm versus the other. So, just telling us that there are going to be strategies that we can use to reduce the cytokine release syndrome for our patients. And then, now I want to talk a little bit beyond, the CAR-Ts and bispecifics. So, what we used to call immunomodulatory drugs, there is a newer class of drugs with, that belongs to that same family, but they're called CELMoDs, because they modulate the immune system. And there are two different agents, iberdomide and mezigdomide, that have different ways in which they can affect the proteasome machinery in trying to kill myeloma cells. One of them is more, active or hypothetically more active and more proliferative kind of myelomas, and the other drug is more immunomodulatory or cellular modulatory in nature. So these agents bind to a protein called cereblon, and that reduces the likelihood of degradation of certain proteins within the cell that can lead to this modulation. So with iberdomide, this particular CELMoD was studied in an open label dose escalation and expansion study on its own, and then in combination with other therapies. And my colleague, Dr. Saad Usmani from Emory, is leading this study. And what Dr. Usmani has shown is that iberdomide was active on its own, in about 30% of the patients, but in combination with daratumumab and with bortezomib, along with dexamethasone, it appears to have, a very similar safety profile to what we have seen with, lenalidomide or pomalidomide. So, very similar kind of, safety has been observed. And then, the overall response rates, even in patients who have had these therapies before, appears to be, quite high. So, very, very promising results, even in patients who have seen other drugs in that same class, even in patients who were daratumumab or bortezomib refractory getting this combination, they appear to respond. So that gives us hope that there is this new class of these oral therapies coming that will actually be more effective for our myeloma patients. And then same is true for mezigdomide. This is a little bit different than iberdomide in terms of how quickly it can act on proliferating myeloma cells. So this may be an important cell mod for our high risk patients and patients with extramedullary disease. And Dr. Paul Richardson had presented these early data showing an overall response rate of about 50%, or rather, sorry, 40%, in all the patients, but 50% in patients with prior anti-BCMA treatments. And now mezigdomide is being combined with bispecifics and other proteasome inhibitors. So we are going to hopefully see more data with this particular cell mod later this year at ASH. And lastly, I do want to mention, this another very interesting mechanism of action, being called immunocytokine. So this is modakafusp alpha, which is a CD38 targeted treatment, but it delivers interferon alpha 2b to CD38 positive cells, and CD38 is the same target that daratumumab and isatuximab utilize to help kill myeloma cells for our patients. So very interesting data in this particular study. You can see that this study was had one part where there was a dose escalation to figure out what's the right dose for patients, and then there was an expansion of 2 different doses, and this therapy is given either every 3 weeks or every 4 weeks. But if you look at the patient population enrolled on each of these on the study, vast majority of patients, 85%, 85 out of 100 patients had prior anti-C38 antibody, and they had become refractory to it. So despite that fact, what we see in patients here is a response rate of 43%. If we look at patients who were either daratumumab or isatuximab refractory, we're seeing a response rate of 39%. So despite the fact that they had, the patients had seen CD38 treatments, the response rates were quite high. In prior patients who had BCMA exposure, overall response rate was 27%. And in those who did not have BCMA exposure, it was 60%. And, the important thing about the response is it's durable. The median duration of response was over a year, 12.5 months. So, all of these therapies are very exciting. And, there are a lot of possibilities for our, for us to use each of these therapies in earlier lines of treatment. This is what we're doing for the CAR T cell therapies and the bispecifics, but the cell mods and modakafusp won't be far behind as well. We just have to come up with a good rational way and figure out which patients would benefit from which therapies. And the key messages of measured hope, that there is a better future ahead for all our patients. So and we're all in this together, marching towards that goal. In the end, I would like to, acknowledge the myeloma service team at MSK, as well as our transplant cellular therapy team. And thank you so much for this opportunity, Dr. Dury.
Well, thank you. Thank you so much, Saad, for that comprehensive overview of these exciting therapies, the immune therapies, and then also these more targeted therapies that you just discussed at the end. while you've been talking, a lot of interest, a lot of questions coming in, and I don't know how many we can handle, but I think that one key question is related to the sequencing. There's so many exciting things, and so I think that one important question comes in from Jack Aiello, for example. If a patient has relapsed on a BCMA CAR T, would you consider a BCMA bispecific, or would you move over to a different target? And so we already have some data that relate to that. So maybe you could comment on that first. Relapse for BCMA CAR T.
Yes, we have some real world data, Jack. And by the way, Jack, it's good to know that you're here on this platform. So we have data from the CAR T consortium that was actually presented at ASH, looking at the real world experience of patients receiving ide-cel, and then what happened to their outcomes and what subsequent treatments they received. And what we find is, yes, you can use other bispecific therapies, but the duration of exposure has to be, of previous exposure has to be more than 6 months. So that's not just from the CAR T consortium data, but also from the Mount Sinai experience, and there are a few other examples of experiences. So if someone had a BCMA CAR and they got more than 6 months of response, and the CAR T cells are gone, if the myeloma starts coming back, the BCMA on those myeloma cells doesn't go away, and one can utilize a BCMA-directed bispecific. However, if they did not respond and they're progressing, then it's better to use a different target. So use a GPRC5D in that case. So that's how we're thinking about it right now. But I think we'll have more data later this year, because one of my fellows is actually looking at this and also looking at immune profiling to figure out if we can tease out who would benefit from one strategy versus the other.
Right. And as I think actually Jack knows, we do have this immune therapy registry or database starting. And I think, Saad, you're participating in that, where we're trying to have real world data so we can try to answer all these questions. Can you go from CAR T to a bispecific, from a bispecific to a CAR T? And then what happens if you switch from one target to another? But I think that what was exciting to me was to see the very strong data with the GPRC5D, both the bispecific, the talquetamab, as well as the early data with the CAR T with this target. Very exciting, actually. Let's see. Let's go through some of these other ones here. Sorry. Can you try several bispecifics? I think that's certainly true.
Yes, we can. In fact, we have anecdotal experience, with, someone, who did not respond to one bispecific antibody because the target was different, responding to another, bispecific antibody. I think, just as Dr. Dury said, all of us are trying to put our cumulative experience into this big, International Myeloma Working Group, database.
Right.
And, it's led by, our colleagues, Drs. Tom Martin and Yilin. And so we'll get to understand this better. How do we, sequence these treatments?
Right, exactly. Then there's kind of a sensitive point here. A patient with kidney failure, are they eligible for bispecific antibody trials or treatment? Is there an exclusion by renal status? I'd imagine if you have renal failure, that's a problem, right?
Yeah, for clinical trial purposes, because these were early phase clinical trials, I think, there was a cutoff for estimated GFR of 30 or more. But in the
Right.
real world experience, we are treating patients, who have, lower EGFRs, because we need to we need to provide these treatments for our patients. So the way,
Absolutely.
yeah. So that will be another benefit of the cumulative wisdom that we collect under the International Myeloma Working Group umbrella in our immune database.
Right, right. We'll see how that all works out. Yes, yes, yes. Out of nowhere, star LLD lenalidomide patch. Do we have experience with that? I don't know that anyone's used that particular patch. Does anyone? Anne, did you know about the star LLD lenalidomide patch?
No, I have not heard of it.
I've actually heard of it, but I haven't seen use of it.
No.
Yes, yes. Well, I think that we've given a lot of insight to patients that these are so striking new therapies. So many of them with promising results. 62% response seems to be a magic number. Many of these bispecifics have a 62% response rate. I don't know what that means. But maybe in closing, we could have some comments from each of you. Maybe Rafat, of all of these exciting therapies, what are your top, 1, 2, 3 that you think are really going to have an impact moving forward? You're muted. Yeah, you're muted. Yeah, so you need to unmute.
So you heard how complicated the field is. It's really not an easy answer. But I've been, doing myeloma for a long time. And, I remember the early days of testing lenalidomide and bortezomib and the responses we got. And then we get the carfilzomib, and then we get the anti-CD38 antibodies. And we studied those in relapse patients and very difficult patients. What I have not seen is the responses we see using bispecific T-cell engager in patients with advanced myeloma. I mean, when you look at patients who have, no counts, have a plasmacytomas growing everywhere, and you basically you were between, you almost were able to get them on clinical trials, almost met the criteria for clinical trials, and you put them on this bispecific T-cell engager, and then in 6 weeks, they back on the motorcycle. It's just unbelievable.
Right. It is remarkable.
So I think the bispecific T-cell engager is just opening the door for understanding something really important, because we have the myeloma cells in the body and we have the T cells in the body. Why? Right. You just need to bring them close to each other, and that's when you get the benefit. Is it really that simple? I don't think so. And, basically what I tell the patient is that, when we give you the the bispecific T-cell engager, it's like when you're having a bad infection, the T cells get activated, they get angry, they produce cytokines. Some of these cytokines are good, they're destroying the myeloma cells, but there's some of the cytokine causing the fever, the tachycardia, hypoxemia. So I think the science is going to be amazing when we discover how these T cells are now recognizing the myeloma. What is the antigen? Is it really the BCMA antigen, or some of these, other antigens that we, we don't know? So I'm really excited about bispecific. I think the way that we use them now, even in advanced disease, the ability to manage the side effect is incredible. And I think that's really where we're going to build the future of myeloma therapy around that.
Fantastic. So, Anne, I'd be interested in your comments in terms of patients that you've seen. We haven't really talked about this for the BCMA bispecific, like the teclistamab. There are concerns as patients stay on the therapy about the infections.
Yes,
However, with the talquetamab, this seems to be less of a problem. Do you have any comments about that?
So I do a lot of inpatient myeloma work, and I agree that the bispecific teclistamab, we've had quite a few admissions since the beginning of the year, and we've seen some nice responses from a myeloma perspective. But unfortunately, some patients have had to discontinue therapy. We've had some very challenging infections, as Dr. Usmani mentioned during his presentation. The infections are quite problematic at times. We've had some fungal infections and some issues where patients had to discontinue therapy. So great drugs for myeloma, but again, come with some issues that are, quite challenging. So again, from a myeloma perspective, some very good
Dramatic
outcomes.
responses, yes, yes.
Yeah.
So I think just my 10 cents before I go back to you, Saad, for some final comments. But I mean, with that in mind, for me, the CAR T approach, the one and done, you have a decisive therapy with a CAR T that is working. That is more attractive in my mind. And if we can come up with a second generation or a third generation CAR T, maybe incorporating both BCMA and GPRC5D, whatever. Maybe for me, if those could be made accessible, the problem is access, that would be a way to go. What do you think, Saad, in the balance between the bispecifics and the CAR T?
Yeah, I think, there is clearly merit in, the CAR T technology potentially, having, if we can overcome the cost, accessibility globally,
Right.
and reliability of, how quickly we can produce it and get it to our patients. I think, that approach of giving it and patients recovering from it, and then not being on anything, is very attractive. But we have our work cut out. The other piece of this is, I think, we are probably going to have patients, who are not going to be eligible for CARs because of age or comorbidities and other issues, where I think the bispecifics may come into play. But these are good problems to have with those responses and figuring things out. So I do feel that CARs will win, for majority of patients, but then we will always have room with bispecifics. I think to Anne's point, we are learning to limit the duration of treatment with bispecifics. And I want to share one anecdote, because it's one of my patients who was on the Majestic-1 trial, who came off of treatment because of recurrent URIs with funky infections, like Anne said, after 8 cycles of treatment, and then stayed in an MRD negative state without any treatment for almost 3 years.
Wow.
Just like they would with CAR T cell therapy, and they had never been off of any treatment. This was their 16th line of treatment, and they had been always on something continuously. So I'm just sharing that for some patients, even the bispecific use for a short duration would be able to give you the same outcome as CARs.
Right. So I think that this is a key point, and as I know you're aware, Saad, I think that some studies with that limiting the duration will be quite key moving forward to get the efficacy and try to limit what can be pretty challenging toxicities with those infections. Okay, so I think that we've had a lot of really excellent presentations and discussions, and so I'd like to thank all of you for participating. Take time out of your really, really busy schedules. Anne, Rafat, and Saad, really, really appreciate it. You can have some late dinner now. I'm not sure how you're going to handle that, but